Hello, I'm Karen Swartz, a professor of psychiatry at Johns Hopkins, and I appreciate the opportunity to share information about the Adolescent Depression Awareness Program with you today. The Adolescent Depression Awareness Program, or ADAP, is a universal education program taught in high schools to bring high-quality information about depression and anxiety and bipolar disorder to students. Today, I'm going to talk about the development of the Adolescent Depression Awareness Program, show you a portion of the program so you get a sense of what we cover, discuss the results from the Adolescent Depression Awareness Program, and then finally discuss the role technology has played in facilitating a broader dissemination of the program. Let me start about why we did this in the first place. In 1998, there were 3 suicides in the Baltimore area within a month and a half. And with those 3 tragic deaths so closely together, the community came to us at Johns Hopkins to say, what can we do in the community to help? What we thought about was the fact that most teenagers do not get assessed or treated in a timely fashion. Teenagers are often suffering with depression without any care. And so our thought was that depression education done in the schools can lead to a change in attitudes about depression and treatment, which hopefully will result in changing behaviors, specifically health-seeking behavior. The mission of ADAP is to develop a school-based curriculum to educate high school students, teachers, and parents about teenage depression nationwide. That was our original goal. Now that we have had distribution of the program around the United States, we hope to find international partners and further expand the program. I'd like to take you a little bit through the development of the program so you have a sense of how this all came to be. So as I said, initially, we were just developing the program where I was piloting it with 2 colleagues in local schools. We then took several years to revise and create a program that we thought the curriculum was excellent. And this is with psychiatrists and psychiatric nurses from Johns Hopkins doing all of the teaching and training. We then decided that if we wanted to be able to expand, we needed to think about ways to train the teachers in the schools to actually do the teaching, to provide the curriculum. So once that was finalized, we did a pilot locally and then started doing trainings where I would go to other locations, train the school teachers and counselors, and then they would teach the program. This last phase is where we've been able to have a broader national expansion because the school-based instructors are not only being trained with local trainings, but we now in 2020 were able to launch a web-based curriculum where the training of the teachers can all be done through our website, as I'll talk about later. When we think about the program itself, just a few details. It's roughly 3 hours. It can be taught as either 3 individual classes that are roughly 60 minutes or 2 classes that are 90 minutes. It's a mix of lecture, discussion, videos, video assignments. For example, we learned by being in the schools ourselves that if you watch a video and the students don't have an assignment, they're more likely to not pay attention or nap. A homework assignment and a number of group activities. Again, this is targeted for high school students, so around ages 14, 15, 16. And so they enjoy working together on projects. What we're trying to do is teach the students about medical thinking, medical decision-making, and make comparisons between depression and other medical conditions to reinforce the idea that depression is a treatable medical condition. And we've learned that you have to have different options in the way you're teaching. What I'd like to do now is just show you a little bit of the curriculum. As I said, this is typically a 3-hour curriculum, and we obviously don't have time for that. So I'm just going to show some highlights. One of the first concepts we introduce is that of little d versus big D, where we talk about the difference between the kind of depression, little d depression, that's normal sadness, and compare that to big D depression, major depression, which is a medical illness with specific symptoms. Now, ninth graders sometimes have a little trouble with that idea of a symptom, an illness. And so we developed an exercise to do as a group with the students where we ask them to think broadly about medical illnesses and symptoms. So we start by asking them, is a cough a symptom or an illness? And they'll say, oh, that's a symptom. And then we ask the kinds of illnesses that could go along with cough, essentially generating the differential diagnosis. We then go through a multi-step process to say, if you're the emergency room doctors, you're in the clinic, how will you figure this out? So we help them come up with the multi-step process to evaluate, like ask questions. And then we have them think, what are the kinds of questions you might ask someone with a cough? The second step is do an exam. What would that involve? So obviously that would be vital signs, listening to the person examining them. And then the third step is we ask them to think about the tests they might do. Now, these are modern students, so they're always thinking about MRIs, and we try to bring them back to cough, thinking about an X-ray. Next, we show the students an X-ray that includes an area where someone has pneumonia. And then we'll go back and review and ask them, based on the illnesses you came up with, what do you think this might be? And they're usually pretty good at identifying that it's pneumonia. We then talk about the idea that we made the diagnosis by looking for symptoms that come together and stay. So we go through the symptoms of pneumonia, talk about the examination and test results, and they say, right, we get it. You diagnose by looking for symptoms that come together and stay. But then we will ask the students, why are we talking about pneumonia when this program is to teach you about depression? And at least thankfully, in every classroom where I've taught, one of the students can see that it's the same process. And they'll say it's the same process to diagnose depression as it is to diagnose pneumonia. And so with the level of subtlety, which is low, that is good for students, we go right into a discussion of the symptoms of depression and then go through them one by one. That's not obviously what you as an audience need to know. You know these, but we talk with them about mood changes and anhedonia, the kind of physical changes that people go through, the changes in concentration, the guilt. And this is the part of the program where we talk about suicide. We talk about the fact that suicide is an emergency. And if someone is having suicidal thoughts, it's critical to tell an adult right away. Because again, they're not being taught by psychiatrists or psychiatric nurses. They're being taught by health teachers or maybe counselors in the school. We have a slightly other discussion, but we end this first lesson by asking them to think if there's a difference between being diagnosed with depression and being diagnosed with pneumonia, doing that comparison. And that's to allow the students to talk about issues related to stigma. Is there a stigma associated with depression, which unfortunately there still is. And this is an opportunity for them to say, for example, I'll ask them, if I had depression and I were out for 2 weeks and you had pneumonia and you were out for 2 weeks, would it feel the same coming back to school and talking about why you were away? And so that's an important discussion about stigma. On the second day, we primarily have the students watch a video in which young people who have had depression and bipolar disorder talk about their own experiences. The third day is another interactive video where I'm interviewing a young actor, and he will describe and act out demoralization, little d depression, major depression, big D depression, and then also mania. Since young people with early onset depression are at higher risk of later developing bipolar disorder, we think it's important to at least have some information about bipolar disorder. And then we review with the students different mood states. So we talk about the fact that if you're feeling well in the middle, your mood varies day to day. It's not the same every day. So with depression, it goes low and gets stuck. And then with mania, you can have high moods that are followed by the low moods to get them a concept. We then talk about treatment options and then a little bit about the kinds of negative behaviors you can do when you're depressed, like substance use, alcohol use, etc. And then we finish each day by talking about what you can do. One way we talk about how you can share information is by doing a public service announcement where the students get together and generate information. We say, you're going to do a public service announcement. Imagine it's going to be on the radio. You want to have 5 facts about depression, or 5 myths about depression, or 5 behaviors you can do, or 5 adults you can tell to get help. And so they work in groups and then present to each other. And that's nice because it gives them an opportunity to review everything that's happened over the typically 3 days of the course, and then present that information to each other. The very final thing that happens on each day is to talk about what you would do if you worried about yourself or a friend. And so we talk with them about telling an adult. We think it's very important to reinforce that with something serious like depression, you don't want to try to figure it out just with your friends, but you really need to tell an adult about your concerns. And then we review with them the sorts of adults that are in their lives that would be good people to talk to because they would take action, but also that they would know what to do. So we reinforce people at the school as well as their parents. That's a little whirlwind tour in a few minutes to give you an idea of the kind of content. Now I'd like to talk with you about how we have evaluated the program to see if it's effective. We always wanted to make sure we weren't just doing this without any independent assessment of its effectiveness. And so we developed the Adolescent Depression Knowledge Questionnaire, the ADKQ. We've done many versions, but I'm going to show you some data from the first version where we did 20 items. We made a decision not to get detailed information about the students because that would require our getting individual parental consent. By doing this as a typical high school class, we didn't need parental consent. We needed just the consent of the teachers. But doing that, we were allowed to ask knowledge questions and attitude questions, but we were not able to ask students, have you had depression? So I don't have that sort of data to present. Our first ADKQ was 20 questions. 13 were yes, no questions about knowledge. And then we asked the students to list 5 symptoms of depression and 2 symptoms of mania. Let me show you some of our results. First, showing you what kinds of questions we have. So these are 4 representative questions from the ADKQ. Things like depression can be controlled through willpower. Obviously, it's important that students know that's not true. A person with depression always feels sad. Again, because so many young people have irritability, we thought that was important to assess. Depression runs in some families. Yes, that reinforces that it's like other medical illnesses. Someone who has a major stress always develops depression. I mean, obviously that's not true. So these are the kinds of things we were asking. Now, looking at some results, before we did the study, and this was from our 3rd year of doing this program, so that would have been back in 2001, we set getting 80% correct on the ADKQ as achieving depression literacy. So a good mastery of the information. These are results from a study that we did at the beginning in a large public district with about 3,000 students. And what we did is do a pre-test before teaching the curriculum, and then gave the same ADKQ as a post-test 6 weeks after the curriculum without any announcement. So it was unannounced. The students didn't know they would be doing it that day. We didn't want them to study for it. We wanted to see what knowledge was staying with them. As you can see, we had very rewarding results. We had about 20% that had depression literacy on the pretest, and over 60% that achieved that by the time of the post-test. For this group of students, a small number of psychiatrists and psychiatric nurses from Johns Hopkins did all the teaching. And so we were able to first have the proof of concept that we can teach this material that's doable. We then said, can we teach others to do it? Because the question was, how are you going to do a broadly disseminated program if all of the information, you need a psychiatrist or nurse to do it? So we did a study with our colleagues in the nursing school where we trained nursing students to be the instructors. And so in real time, we did a comparison where some classes were taught by the ADAP team, the psychiatrists and nurses who developed the program, and some were taught by the nursing students who are not experienced clinicians. And you can see the results. We had nearly identical results. Now, I have to say, as an experienced psychiatrist, I was slightly taken aback. I thought we would be even better. But as the project leader, I was really excited to see that inexperienced non-clinicians could successfully teach the curriculum. And so that's what this showed. That encouraged us to move forward with our plan to actually see if we could train high school teachers and high school counselors to do the teaching. And so in the next study, we were comparing school personnel as the teachers to the ADAP team. To train the ADAP instructors initially, we did a one-day training where I trained them in person, really an in-service about mood disorders in adolescents. This included a parent coming to talk about his daughter's experience with depression and her suicide. We had a panel who would come and share their experiences. And then what we did is we compared how well the students did being taught either by the ADAP team or 20 school-based instructors. And this was done in the same time. So there's not a cohort effect. It was the same semester that either the school teachers were doing the teaching in some schools and we were doing the teaching in other schools. Obviously, our hope was this would be effective because it's neither sustainable nor cost effective to think that you need psychiatrists or psychiatric nurses. So from a public health point of view, we were really hoping that we would have effective teaching from the school-based instructors. And that is what we found. Again, pretty remarkably, the results, meaning the improvement, achieving depression literacy, was nearly identical if you're comparing the ADAP team, psychiatrists, psychiatric nurses, to school-based instructors. So this was really exciting because then we could shift to put our efforts into training more instructors so that we were able to reach many more students. We then wanted to have a randomized controlled trial to really test whether the program was effective. I worked with my colleague, Dr. Holly Wilcox, who is a public health scientist. She's a faculty member in the School of Public Health and an epidemiologist, to see, does ADAP increase depression literacy, and is that sustained? We also had a very small group where we got parental consent to test the second hypothesis that ADAP will lead to higher treatment seeking. So to show those results, we did the program in 64 different schools in 5 different states. Schools were matched at the 5 locations and then randomized. So we were in Delaware and Maryland and Michigan and Oklahoma and Pennsylvania. And so schools in the same district were matched and then either went into the intervention schools where I trained the teachers and then they taught the first year, or the control schools where they did the same measurements, the ADKQ. And then The next year they got trained and could teach the program. So it was a true randomized controlled trial where the first year there was no intervention for the controls and the students were taught ADAP in the intervention schools. These are the results, which again are very rewarding. There was a slight change in the ADKQ because we had to go from a form that had to be hand entered into a form of the ADKQ that could be Scantron. And so what we found was that there was no difference between control and ADAP schools on the pre-test. The initial post-test was done at 6 weeks, and the follow-up post-test was done at 4 months. And what we were able to demonstrate was an improvement in depression literacy, the percent achieving depression literacy at 6 weeks that was sustained at 4 months. So very rewarding. We were also doing a study of the teachers that we trained. So 65 of the teachers who were trained completed the ADKQ at baseline and then follow-up. Interestingly, the teachers who had higher depression literacy themselves were more effective and had students with higher depression literacy at the follow-up assessments, which is not surprising. If you actually believe that depression's a treatable medical illness, you are much more likely to be able to teach that to others. Importantly, 46% of teachers said that at least one student came to them with concerns about themselves or a peer. And so our hope that changing knowledge will change help seeking, I think, is borne out by the fact that students were coming to the teachers after the program. This is just to give you a scope of what we've done. When we were teaching initially in the first 6 years, we reached about 7,600 students. When we added the nursing students, we were able to do more. And then as we have gone to not only in-person, but also web-based training, we've been able to greatly expand the program. Obviously, that's more time, but it's also an escalating ability to reach more students, which is really rewarding. I wanted to share that we have a website, www.adapeducation.org, that has a lot more information about the program and is where people are able to sign up to take the training to actually teach the program to others. And so that's where we have the teachers come, they click on the Start Teaching Today. We do have some requirements that someone is a school-based professional. We don't want parents to do it or random people in the community, but we've had pretty good success in getting a much broader reach where we don't have to rely on funding, that I'm able to go out and do a training. I didn't mention ADAP Junior High. Our current projects are to expand the ADAP program into more states and have a broader reach. We feel very comfortable, especially after the randomized controlled trial, that we have an evidence-based treatment. What we're trying to do now is to develop a program for younger students, for middle school students. So what we know is that school-based education programs have the potential to increase knowledge and awareness and to encourage students to seek treatment. We see that from the multiple studies we've done, and most importantly from our R01, the randomized control trial. We know that ADAP is an evidence-based intervention that increases students' knowledge and improves their attitudes about depression. We also know that ADAP has been successfully taught to school by the school-based educators. The students being taught by these educators are also achieving higher rates of knowledge, higher rates of depression literacy. And then finally, our web-based training approach is facilitating broad distribution. Because of generous donors and philanthropy, we're now able to offer ADAP training to any high school teacher in the United States who would like to do it. And then we can offer the teaching materials to them similarly at no cost. So the limitation now is really getting the word out. So it's exciting to share this with you as well. I really appreciate your interest in our program and would be happy to answer questions. The organizers have my email, and I'd be happy if you have other questions about the program to answer them. So thank you very much for your attention.